All right. First, Dr. Lambert. Dr. Aaron Lambert created, sorry, Dr. Aaron Lambert completed his undergraduate and medical school education at Marshall University in Huntington, West Virginia. He went on to complete his family medicine residency at Marshall with a certificate in the Rural Health and Leadership Program, serving as chief resident in his final year. He is currently a clinical associate professor and residency program director at Cabarrus Family Medicine Residency in Concord, North Carolina. A graduate of both the Faculty Development Fellowship at UNC Chapel Hill and the National Institute for Program Director Development Fellowship, he is an active educator with all levels of learners and is an advocate for full spectrum family medicine care. His particular interests are in competency-based medical education, wilderness medicine, and rural health. And our second speaker today is Dr. Linda Montgomery, who has been in academic family medicine for over 20 years. She has served as a program director for the University of Colorado Family Medicine Residency for 11 years and is now the vice chair of education for her Department of Family Medicine at the University of Colorado, overseeing all undergraduate and graduate level training. She also recently served as the chair of the education subcommittee for the University of Colorado's GME office for 5 years, helping to oversee the educational needs of the 1,200 GME learners and faculty development across the University of Colorado School of Medicine. She currently is serving as the leader of the Society of Teachers of Family Medicine's CBME task force, and her professional passion is figuring out models of care and teaching that promote the quadruple aim for family medicine. All right, with introductions out of the way, Dr. Lambert and Dr. Montgomery, the floor is yours.
Well, welcome everybody. Glad to be here today. I'm looking forward to talking to you a little bit about residents. I know we want to touch on ILPs and resident assessment, but I'm going to try to emphasize a little bit about how to get residents engaged as your program is trying to transition into more CBME programming. Wherever you may be on the spectrum of that, there is always room for more engagement of both residents and faculty. So I titled this CBME Meets the Giant because we get all excited about plans for transitions and new things and new teachings. And then we sometimes come up against a bit of a boulder in the road that is getting everybody else on board with all these things that we're so excited about. And it comes, I don't know if anybody knows this book, but this was one of my favorite books as a little kid. And for some reason, it popped into my head. It's about a story where Mickey comes into a village and there's a giant who's been plaguing that village and put big boulders in the road so that they can't get out. And so he tries to go face this giant and trick him into leaving. And he uses a couple of different challenges that he loses on purpose, and in the process tricks the giant into draining a lake and throwing the boulder out from the road. And then his final challenge is to squeeze water out of a rock. And the giant goes first and picks up a big rock and squeezes, and no matter how strong he is, he can't get any water out of it. And Mickey has a trick. I don't fully understand this, but he had a piece of soft white cheese that I guess looked like a rock, and he squeezed it and water came out. And I'm not understanding the biology there, but in the story, it was really great because it scared the giant and the giant ran away. And so my pitch to you today is we need to figure out how to squeeze water out of this rock and get residents who maybe aren't as excited about change as we are on board with things. So I want to talk for just a couple minutes about competency-based curriculum and kind of refresh on that, and then talk about a few of what I think are key factors in getting residents on board with these great changes that you're making, and then have time for some questions. And disclaimer, I don't have any conflicts of interest, but I also don't necessarily have all of the right answers in getting residents engaged. In CBME, it's not like every single one of my 24 residents is falling all over themselves to participate in some of these things. But after a couple of years of transitioning and new programming, we have learned some lessons along the way. So I just wanted to share some of those things with you, and hopefully they'll be helpful. So just to go back over the kind of 5 pillars of CBME, remember we are thinking about education and curriculum that is based not on the courses or the rotations that they must go through, or even the content of a board exam. It's based on the outcomes. What do you want this physician to look like and be able to do when they graduate your program? It's based on the idea of progressive sequencing. So each experience should build ideally on something they've already learned. And getting more complex appropriately as they go through. We want those learning experiences to be competency based. Everything we're teaching should be tied to some future skill or knowledge set that they need. And then having good assessment, both assessments of the residents as individuals and assessment of our programs to make sure that our programs are healthy and doing the things that we need them to do. Being outcomes based means that we are trying to create physicians who are prepared to meet the needs of our communities. That's something my program really emphasizes. We are a community-based program, and we are very much integrated and networked into our communities, as I'm sure many of your programs are as well. And we want to make sure that the doctors we're putting out don't just score well on their board exams, but they actually have the skills that their neighborhoods and their towns and their practices need. And that they're effective health professionals, that they didn't just make it through 3 years and not fail anything. That's not really good enough. We want to know, do you have the skills? Can you do the procedures you need? Do you have the medical knowledge that you need for your area and your town and your part of the country? So some of the things that we have learned at our program, and I have also learned as being part of the CBME task force, as we think about outcomes as being the central part of CBME, there were 5 words that kind of came to mind as I thought, how did we implement this in a way, or have we had to change it after we implemented it in ways that would get both residents, because you can make all the great changes on paper that you want, but if the people who are living out these changes to it, it's not going to be very successful. So the 5 words I thought of were education, involvement, time, collaboration, and entrustment. And I want to explain those each just a minute. Some of this may sound familiar from the slides that you were looking at, and some of it might be a little bit different. The first thing we need to do if we got to get anybody on board is educate them, right? Just like our patients, if we can explain to them what we're doing and why we're doing it, then it's going to go a long way. So we need to make sure that our residents and our faculty, for that matter, understand what CBME is. There was a lot of confusion the first couple of times that I tried to explain CBME to my residents. But I thought we were already going to be good doctors with what we were doing. Why do we need to make all these changes? Why do we need to do anything different? So explaining to them how this is different, it's a different way of delivering education. It's a different way of measuring what you've learned, and explaining that it's oriented around competencies and skills and not a pass fail on a test or a rotation. They need to understand why that matters, that we're to make a curriculum that teaches stuff that you're actually going to need to know and learn. How many of us got degrees in college or took classes in high school and said, oh my gosh, I'm never going to need to know this? And sometimes we were right and sometimes we weren't. But making sure that they understand we're really trying to tailor this education to things that they need to know. And then also just why should they like it? What's in it for them? Well, typically CBME based outcomes based education is a little more flexible. It's a little more learner centered. So if there are things that they want to learn, there should be a pathway to be able to tailor that education. And that is something that's very valued by our current generation of learners, is to be able to have some control and some say and some voice over what their education is going to look like. And usually it's more active learning. It's a lot more about doing and less about sitting and listening. Typically, is pretty well favored. I like to explain CBME with this photo. It's called Medieval Baker and the Apprentice. Perhaps you've seen it. And the question I give people is, which one of these is a baker and one is an apprentice? Which one is the apprentice? And how do you know? Is the apprentice the one in the blue shirt who is watching the baker so that they can learn? Or is the apprentice the one in the brown shirt putting the bread in the oven under the supervision of the baker, because now he's progressed enough that he can start doing it for himself? To me, that's kind of CBME in a nutshell. At some point in their education, they will be both of those people, maybe even in the same day, depending on what they're doing. They may be both of those people. They may be the one watching to learn, or they may have developed enough skill that they can do it and have somebody watching and coaching them. So that's been a useful discussion starter in our program. The idea of entrustment hopefully is not a brand new word to anybody at this point, but the concepts might still be a little bit unfamiliar. But in the idea of asking the question, how much can I trust you? And when I say that to residents, that tends to kind of, I don't know, stop them in their tracks just a little bit. Like, what does this have to do with trust? I just thought I get to do these things because I'm on this rotation. Like when I put the word trust in there, you can see on their face that it kind of elevates the accountability a little bit. I'm asking you, what can I trust you to do or not do, and then show me. So this is a real low hanging fruit if your program is still pretty early on in trying to get into CBME. If you look at the evaluations and the assessments that you already have, and maybe you have a 1 through 5 Likert scale, or you have an above average, below average, at level kind of scale, those are kind of tricky when you take very many different preceptors and have them fill it out. What I think is a 4 for a resident may be different than what a 4 looks like to somebody else. But a real easy first step is to switch out your measuring scales for an entrustment scale like the one here. And all it asks is, how much was the resident able to do? Were they just an observer? Did they do it, but they needed a lot of help? Did they do it with a little help? Did they do it completely by themselves and you just had to be in the room just in case? Or are they able to do it well enough that they can teach others? How much can I trust you? And this may be very different on a different skill, maybe on a different day. One day they might really be on fire and they get it all with minimal assistance. And the next day they've had a rough call night, or they just walked out of a really hard patient conversation that shook them and they're going to need more help that day. So there's different kinds of entrustment. There's entrustment of the individual resident in that moment. And there's entrustment in a larger scale over the course of a rotation or a PGY year, or even of the program itself. And so the larger entrustment is based on lots of different kinds of feedback that you can see here, and it really works best if you really want to know how much can I trust this person to graduate them or to promote them on to the next PGY year. It works best if you have lots of feedback, lots of assessments from different people, from different perspectives in different settings, where you can put it all together and make those individual assessments into one big overall outcome. Of course, all focusing toward that ultimate outcome, whatever that might be, of the skill set you need. But entrustment is a really valuable word that I've found that I've added to my vocabulary in the last couple of years. Collaboration is also important, and this is where we kind of get into the ILPs. I don't know about you all. In the past at our program, not every resident had an individual learning plan. Sometimes we call them IEPs. And they were kind of had a stigma around them, right? Like if you had an IEP or an ILP, that meant you were not up to speed. That meant you had some deficiencies and somebody wrote one out for you so that you could fill a gap. And if you had an ILP, that was kind of a scarlet letter on your forehead. And that was never what they were meant to be. So I was actually pretty pleased when the new requirements came out saying everyone should have an ILP, because that's what it was really meant to be. Everyone's learning curve is a little different. Everybody's educational journey is a little different. So why not write it down for all of them? So an ILP ideally should be created together, collaboratively between the resident and their advisor or their coach. In our program, we ask our residents to make their initial draft of their goals for the next 3, 4, 6 months. And then they bring those with them to sit down with their advisor, and their advisor can refine them, can fine tune them. Maybe they're a little too vague. Maybe they totally missed something that they really need to be working on. Maybe they were pretty insightful and they got them all on the first try. But the goal is working together to make a good plan, and storing it someplace where the people who need to see it can access it easily and access it often, so you keep coming back to that. One of the other places for collaboration is in electives. Sometimes we tend to look at electives the way we looked at electives in college. What can I take that's an easy A? What can I take that's going to be fun? What can I take that's not going to keep me in the hospital for 12 hours a day? But with a CBME mindset, we really should be keeping that end in mind. What is your future career going to be? In our program, every time we sit down for their ILP meeting, we ask them, if you had to pick today, what job would you take? Because that helps shape what they need to learn while they're with me in residency. If they want to be an outpatient doctor in a large town, a large city, they're going to need different training and different resources a little bit than my resident who wants to go to a critical access hospital 2 hours away from that city and operate by themselves. So thinking about electives, sitting down with the resident and talking through that together, saying, well, what is it that, if you had to choose today, understanding that might change, if you had to choose today, what do you want to do for a career? And let's pick electives that are going to help you get those skill sets that you need. And then if you're really feeling ambitious, or maybe you're already doing it and mastering it, but we started portfolios here about a year ago that are not the we use MedHub. We are not using the portfolio feature of MedHub. We took it out of that into Microsoft OneNote because you can manipulate it and customize it more. And we are challenging our residents to really collect this catalog of their work over 3 years, just like an art major or an English major might, little samples of what they have done over the 3 years, and reflect on that and comment on that and write it in. It gives them a voice. If they got a bad evaluation, they leave it in and they put their own paragraph of their perspective, either saying, no, this really wasn't what happened, they didn't see the whole picture, or, yeah, I really messed up about then, and here's what I learned. And they can, if somebody else gives some feedback, they can reflect on that again. And I think it really helps, hopefully, at least, we're still early on in it, but ideally it's going to help move toward that lifelong learner who continues to learn when nobody's making them learn, by reflecting back on experiences and things. So that's another place that you can collaborate with faculty and residents together. Just thinking a little bit more about the individual learning plan. So remember this, they really ought to be self-directed at first. What is it that you want to learn? What is it you feel like you need to learn? For all the residents, so that stigma is not there. The stigma went away in our program real fast because everybody has an ILP. So, who knows? Maybe you've got a deficiency, maybe you're doing great. Nobody can tell because everybody's got an ILP and they're all talking about it all the time. You should definitely use feedback from the program and start with that resident. Think that means that whatever the resident wants to learn or not learn, that's what they get to do. That's where the advisor or the coach comes in. To still put some guardrails on things, to point out perhaps patterns in feedback that weren't seen, or things that need to be prioritized more. We're working with a resident right now who's got a couple of deficiencies, but one is more important, more urgent to correct than the other. So helping them prioritize, what do I really need to work on first? That's where the faculty really shine in helping with this. And then involvement. So I think this is a real big key that we have learned along the way. And we learned in our task force as well. We've had 2 residents that have been members of our CBME task force, and the perspective that they have brought has really been helpful and has at times really kind of given us a big course correction on things that we thought were a great idea, but we needed that perspective. So as you're thinking about or you're implementing new ideas in CBME, think about, where can I include a resident or multiple residents? Put them in on planning groups when you're initially coming up with ideas. When you're redesigning your assessment forms or your evaluations, bring residents in with those too and get their input. Send a resident or two to one of these great CBME training courses that are going on. Let them find one who's interested, who's thinking about maybe a career in academics. Send them away to one of the courses to get trained, and then let them come back and do some of the teaching. So it's not just your faculty standing up in front of people. When it was just me, it was a little bit of an uphill battle trying to make some change here, just because it was all a lot of new information and it takes people time to process it. But then I had a couple of faculty who got extra training, and wow, what a difference that made in trying to spread more programming and explain why it's important. And then we got a couple of residents who were excited about it and got on board. And I'll tell you, I'm sure you know, residents hearing a message from one of their peers means a lot more than from an old fuddy-duddy faculty member like me. They can kind of come around to seeing the purpose of it better. And then as you're implementing things, please make sure that you are asking for feedback from residents on these new ideas, on these new processes, because they're the ones who are living it out day to day. Make sure that you are asking for that feedback and then really listening to it when it comes up, and not dismissing the feedback that they give you. One of the things that I think has been most helpful to us is when our residents say something or when they give us feedback, we act on it, but then they see us doing that, and they are more prone to give us more feedback and to be on board with us because they know we're willing to work with them. So think about involvement. Where, if you aren't doing that already, where can I get residents on the team? Let them see all the work that goes on behind the scenes that sometimes they don't know about. And if they come to appreciate it better, they'll tell their friends. Residents need to make some time for engagement. You can make some games out of it. You can do some incentives. Make sure everybody knows what you're working toward and your goals. PDSA cycles, I'll say, don't take very long to do. If you're changing an evaluation form, you probably only need a couple of weeks to figure out whether it's going to work or not, or if it needs adjusted. It doesn't need to be 3 months or 6 months or a year. You're going to know either everybody hates this form and they're not going to fill it out, or yeah, we're getting a lot more of these back than we used to. So think about short PDSA cycles. And even students, if you have students rotating with you, if they're interested at all in education or academics, put a student on, even if it's just for a few weeks while they're rotating with you. Get their perspective, because one, you may recruit your next resident because they feel connected to you, but also you're going to get that perspective of the generation of residents you'll have in a couple of years. So don't hesitate to let them be involved as well. And then if there is any word that has been most impressed upon us in our work at my program in the last couple of years, and I know some others, it's time. It probably been the most contentious word of the 5. If we are going to ask residents to write reflections, if we're going to ask them to create portfolios or to write up individualized learning plans, we've got to give them some time to do that. This is not stuff that most of us were asked to do in our residencies. It's different work and it's valuable, but it is not going to be valuable if they have to squeeze it in over lunch or between patients or in the evenings when they really want to be resting or doing something else, you're not going to get a good product, and the whole thing is going to look like a failure. If we're asking them to be directly observed, if we're asking them to bring us in the room with them so that we can watch them in real time with patients, we need to block their schedule a little bit, sometimes at least, and give them time to do that. If we're going to ask them to be in these work groups to write new evaluations or make up things or to give more feedback, we got to give them time. Some of my faculty were on board with this. I had some who kind of rolled their eyes and said, well, I didn't get any time in my residency to do this, and why can't they just suck it up and get it done? And I had to spend a lot of time explaining we were not asked to do this. There was no portfolio in my residency. There was barely an ILP in my residency. And this is a different type of learning. And if we want to do it well, we need to allow a little bit of time for it. And that's not a bad thing. Focusing on quality over quantity a little bit. I think that was reflected in the new ACGME rules when we switched from 1650 to 1,000 hours. Part of the reasoning behind that was so that we didn't feel the pressure of volume and time clock, and we could make sure that the quality was good. Residents are going to, in order to be successful, they're going to need to embrace a feedback culture. If they are not used to giving feedback, or if maybe they don't get asked for feedback a lot or asked in the right way, that's going to be a new experience for them. And new assessment tools. We actually just changed it again today. We have changed our evaluation that residents give their preceptors on rotation 3 times in the last 12 months, maybe 4. And, that's different. That's a change to their workflow. It's something different they have to explain to their preceptors, especially the ones outside of our department. They have to be open to this idea of let's try this. And if it doesn't work, trust that we're going to change it. Maybe it will be more smooth. Residents have to learn how to be focused on those outcomes, that end goal, and how does that fit their ILP. If we continually are asking them, what are you going to need for your future job? Right now, they can only see 3 feet in front of their face. They can see their residency, this rotation they're on, or the end of this PGY year. We need to keep helping them look past residency to their future job and say, but what are you going to need for that? And let's make goals to help you get there. And they need to learn to accept constructive feedback, and also give it. If you haven't ever read the book, Thanks for the Feedback, we go over that with our residents every year at orientation and kind of do a little quick summary at reorientation with the upper levels. Because if you learn to receive feedback well, you're going to get better at giving it too. So sometimes constructive feedback is hard if you're not hearing things that you like, but that's kind of what that book touches on, is how you receive feedback well when it's stuff that maybe you don't like. And they need to learn to give grace to their faculty and their admin. We're trying the best we can. We're going to mess up sometimes. We're going to suggest a assessment form that doesn't work. But if you get more residents on the planning of that, they're going to see how much blood, sweat, and tears goes into all that planning, and they're going to appreciate it more. And then they're going to tell their friends, hey, look, they're trying really hard, just bear with them. So it can be helpful in that too. Barriers that we need to overcome. Direct observation is hard. Residents typically, on the whole, don't love having the faculty come in the room. But it really is a great way to learn what they're doing and how they're doing it. And that's a whole separate talk for another day. Sometimes it's hard to be flexible with curriculum. We've done it this way forever, and our doctors graduate and they're fine. So why do we need to change anything? Change can be hard. Sharing expectations. If we're all something different, we're not going to be successful. So sitting down and saying, what exactly are we trying to accomplish? So everybody's working toward the same goal. And then having some outcomes you can actually track, so you know if you're getting there or not. And then, of course, the engagement piece that we've just spent the last little bit talking about. So if your program is going on, I'm just not sure what to do next, wherever you might be, maybe you've already made gotten started and you're kind of stalled in the middle, or you're still trying to figure out the best first steps, my suggestion would be look at the things that you already have and see if you can just revise them. You don't necessarily need to reinvent the wheel. Take that evaluation that's got a Likert scale and put in an entrustment scale, and just do that first and see what different feedback you get, and what more useful things you have. If you have resources that have been helpful 10 years ago, but they need updated to be more in line with those 5 pillars, maybe that's a place to start. And then once you get those first steps, educate your faculty, educate your residents on why you're doing it and what you're doing, and then give them some time in some way to continue the work and to feel like they've got some skin in the game and a role to play. And you'll be amazed at kind of how much it moves along. Sometimes breaking things into buckets is a little easier if you think about a few different buckets of work. And maybe there are some people that feel particularly passionate about one thing or another. Dividing it into smaller bites is easier to chew. So put a few people in a work group on one bucket or another, and see what they can come up with. That has been successful for us as well. And I told you I wasn't going to have the silver bullet for all the answers, but hopefully we have something. So that's all I've got to really share at the moment, but I'm happy to talk through some questions or challenges or what have you, or Linda, if you have more things to add.
That was a great overview, Aaron. Thank you so much for that. That was a lot of wisdom. It was like 5 different STFM talks with the highest yield things for programs. I think that is awesome. I'll just start us out with a question. I think that people might have others. I'm curious about a couple of things, but I'll start with kind of my biggest question is around the portfolios and using them for resident engagement. I think it's a brilliant tactic that I haven't done in my program yet, but hope to this year. Wonder about they contribute to their portfolios. Do they then present their ILPs or present their portfolios to the CCC in any fashion? Like, is there a time where they get to present it and then others get to comment and give suggestions, gaps, what faculty think, what the CCC might think?
Yeah, that's a great thought. As we have it right now, the residents are not the ones presenting their portfolios. Their education advisor presents to CCC.
Okay. Yep.
We have given them, again, this was where time came into play. So we give them a certain number of half days a year of portfolio time to work on it, protected time for them to work on it. And they have meetings with their advisor along the way to kind of talk about it. The portfolios are organized by the 15 core outcomes, and there are some question prompts, reflection prompts for each of the 15 outcomes. And then there are certain things that we agreed that the program would automatically drop into their portfolio for them, like patient reports or procedure logs, things like that. But then we ask them to do those reflection prompts and anything else they get. I had a resident 2 days ago. You got a very complimentary email. That I'd gotten an email from somebody at the hospital of good care that he'd given to a patient. He said, "Could you send that to me? Because I want to put that in my portfolio." And so they'll put those, they'll drop those kind of emails in and write a little comments to give context to that story. And their goal is to have their portfolio updated before a few weeks before CCC, and then the advisor will look through, and in OneNote you can search by timestamp, so they can see what's been changed in the last 2 weeks or 4 weeks or 6 months, and so they don't have to read the entire portfolio every time. They can just look and see what's changed within a certain period of time. And our CCC has very much gotten streamlined, I will say, from the old system of just going through all of their logs and their folders. we now go through it by core outcome and say, here's the data they had from last time. Here's the new data they've added for this core outcome that they've worked on. And here's something I think they could continue to grow with. And we just go through that. And for the residents, we try to teach them that their portfolio should feed into their ILP. They sit down with their advisor, look at their portfolio and say, all right, are there certain folders that you're really missing a lot of stuff? Like you don't have a lot of data for core outcome 7. Could we set an ILP goal for you that will help you work on that? And then as they're working on that goal in their ILP, that brings them more data to put in their portfolio that then feeds their next ILP. So it's kind of an ongoing closed loop process, at least ideally. And does it work that smoothly for every resident? Absolutely not.
Yeah,
but
15 is a lot of folders to manage, but I get it that we will need to be doing this if we're truly going to be able to attest to competence in some, especially in some of those harder outcomes. So
right. And one of the things I learned from my residents, one of the feedback that I heard from them when I initially pitched this idea of portfolios, I said, look, I'm going to have to attest when you graduate that you are capable of doing these 15 things. I need you to help me do this portfolio so that I have evidence so that I can say that confidently. Well, the residents later, after struggling through portfolios for a few months, they came back to me and said, look, that whole pitch that you gave us does not motivate us because it sounds like you saying, I need you to do my work for me. Like I was asking them to do all the work for me to help me. They said, you need to come to us and say, this is to help you realize that you are competent, that you're capable, that this is to show you, this is to show ourselves that we know what we're doing by putting it all out there and getting to demonstrate all the things that we've learned. Like you need to pitch it that way and not help me be able to check a box. And so I have changed my pitch on portfolios since then.
Helps you to get that water from the rock. I get it.
Yes.
Right. Yes. No, I think we will. That is a shared journey over time that we will have how to truly engage residents in their own self-directed learning. And it sounds like your residents are getting there. I hope mine and ours are as well. Do others have questions? I know these webinars are always hard to unmute and ask. If not, I'll just keep going with my questions because I know this is about resident engagement. From the very moment or even before they get to you, do you have any tips and tricks about what you put in your first CBME discussion with them? Like, well, can you tell us about it? You said you talk about thanks for the feedback and you do that at your reorientations. And I think that is definitely at the base of CBME is trying to create master adaptive learners. So I think that is critical. But do you show them the STFM webinar that Maggie Karan and Ray Wright put together, or do you do your own version of it? How do you pitch CMB to them first off?
Yeah, no, I actually do. Last year was the first year, when that was first made, and our orientation schedule was already outlined. But when I found out when Maggie and Olivia were going to put that on, or Ray were going to put that on, we were able to rearrange our orientation schedule a little bit so they could watch it live and plan to use it again. By the end of orientation, they're tired of hearing me talk. And it's nice to hear from somebody else, but then we'll have a little discussion afterwards. So watching that webinar is definitely one of the things we do right at orientation. The thanks for the feedback I was using for several years before this came along. How I used it maybe changed just a little bit, the things that emphasized. And then during orientation, they have their first meeting with their advisor and they make their first ILP. And they say, I'm brand new, I haven't even had day one of work yet. What is it that I really want to work on in the first 3 months of residency? And it can be very telling, because all medical school experiences are not created equal, as we know. and it's can be very illuminating of things that they're nervous about. Maybe they didn't have great inpatient peds exposure, or they didn't have good hospital exposure in general, or they never got to do a pap smear or as a student, or what have you. The things they're most nervous about are what are going to come out in that very first ILP. And we found that if you before they do their first day, if you get them an orientation to start thinking, what do I really want to learn? It tends to get them at least hopefully engaged in the process, but at the very least, it gets them used to the process that we are going to be asking you this question a lot starting right now. And that has been helpful. I don't know if others have good tricks that they've used for orientation to kind of get people jump started or not. Feel free to put things in the chat too if you want. If you don't want to unmute and speak.
Anybody doing something different around orienting residents to these concepts? Maybe it's new and it's your first year and your learners are about to come. So I think we're all getting used to what we need to tell residents about. Even if CBME is too big of a thing to bite off at this point, they all have to do ILPs. So being able to describe that to them, that process and why that's part of their what they must do. Erin, it sounds like in orientation, you actually set aside time and carve out time for them to do their first ILP with their advisor. So you arrange time, I'm assuming. You just don't say find time with your advisor. And I think that's a different thing, right? We used to just say, find time, go out for a drink with your advisor, go out for a meal. But now we're saying it should be a richer, maybe not more serious, but a richer conversation so that it should be part of your work of your day. And so that is something I am trying to do, is actually have my residents and my advisors have dedicated time to work on this. Do you continue to have it? Do you carve it out of didactics this time, or how are you dealing with that time issue?
After a couple of things. After orientation is over and they're off to the races. When we have our didactics Wednesday afternoons as well, and the residents are not in their their continuity clinic Wednesday mornings. They're doing some other rotation. So we will often do their advisor meetings during lunch on Wednesdays, because we can take them off of their rotation just a little bit early. We don't have to worry about blocking patient schedules, but we'll have them come over at 11:30 or 12 or 12:30 and meet with their advisor, and then conference starts at 1:30. They're already here. And most of the time that tends to work out pretty well. And then the other thing we started doing that I know a lot of other programs do as well, I think we were probably a little late to the game on this. We started doing more dedicated one-on-one precepting sessions, and where so our residents have two advisors. They have a core, because we have a big faculty, they have a core education faculty who's their education advisor. And then they have a clinic faculty who is somebody who's more of a full-time clinical attending, who works closely with them on kind of seeing patient care, billing, the kind of frontline physician work. And so their clinic advisor gets to have a half day where that's the only resident that they are precepting. But we also then expect them to go in the room more often and fill out assessments on what they saw. And then we block that last hour of that half day so that they can have their advisor meeting and not be rushed through it at the end of the day. So we expect to get more hard copy feedback from that day, but also it's protected time for that. And the clinic faculty, it's actually done well for their wellness too, because, they're seeing patients 8 or 9 half days a week and drudging through inbox management and all that. And they said, look, I just was hoping to teach a little bit, and to have a half day where they are protected and they don't have 4 residents where they're scrambling to see everybody. They can just really spend quality time with their advisee. It's been good for faculty morale, I think, too.
That's great. And I see that Joy's saying that she's a new coordinator developing a program. So we envy you. I think Aaron and I would love to be in that position of being able to make it, make something new and don't have like, this is the way it always was. So Joy, that's great. I think my advice there, that I do know that the criteria for excellence is being that who puts it out? The help me out here, Aaron. It's the Randy works. They have the criteria for excellence from RPS. I think RPS puts it out. Residency Program Solutions. For like $16, you can buy that. And they have a new chapter around CBME. I've not looked at it, but I do trust the people who put it together, including one of our colleagues, Randy. And so I would say, take a look at that. There are probably some very good things in there, but thinking about how you might put, some dedicated time in for ILP creation and this kind of coaching is really important. Yeah. The last question I think I have is around, I love and I'm going to steal it. If you had to pick today, what kind of position would you, and then I wonder, like it came to mind, you could do like, have them do their own gap analysis. Like what would you want to do and what would you feel competent to do? And in that gap, right, would be perhaps some of their elective time choice. Because if they say they want to do full scope rural medicine and what they feel competent doing is like urban outpatient work, then you've got some work there to do. Yeah. So I'd love that question, though. I've not asked. Of course, we always ask, what are your career aspirations? But really the way you've put it in really ties it to what they need to do and what they need to be putting in their ILPs and figuring out what their learning gaps are. So
yeah,
very cool.
And for Joy, as you're building your program and others that might need it, I'll put the link in the chat here in a minute, but the CBME toolkit that we've created has a sample ILP form that is very basic and on purpose. The smaller, the shorter and simpler something is, the more likely people will be to do it. And certainly you can add to it and build to it as your program needs. But if you use that, and that's what my program switched to using. It actually has, trying to see if I can open it real quick and share my screen, but it actually has that question in it. Here, hold on, got it here.
It
let me
does.
share real quick.
I'm embarrassed I don't know that, but
because I was on the work group that wrote this, so I remember. Can you see that now?
Yeah, we can see it. Yep.
So it's in the beginning section. As of right now, my future practice goals include, and then things I still need to work on for my future career. So kind of to your question, I haven't asked it quite the way you did, but I like that, Linda. What do you aspire to be and what do you feel comfortable and what you need to work on lies in the middle. I like that. That's a neat way of thinking about it. But if you need an ILP template or you just aren't happy with the one you have, you're welcome to take this from the toolkit. It's got drop downs for their PGY year, and it's set up in an I, an L, and a P. So the individual section talks about their strengths and what they need to work on. The learning prompts them to reflect back on their last ILP, because you should always be going back to your previous one and saying, how did I do? And then the plan is making their new goals for what they're going to continue to work on. And it's got drop down boxes to link it to the core outcomes if you need to. We added a well-being objective as well, because I think that's important to keep in mind. So if you need that, you can click on that link that I just put in the chat and hopefully there'll be even more helpful stuff than that in there.
And Aaron, I know that your portfolio, you said you're using Microsoft OneNote. I think that's great for me to know. Does the toolkit, I should know this too, the one pagers on portfolios, do you have any? I think the structure of it has been a barrier to us, and I'm just wondering, either on the AFMRD web, toolkit or the STFM toolkit, have you thought about having any kind of examples available to programs so that they can see what kind of structure you could put the portfolios in?
We don't have examples of the OneNote that I've been using because there's so many different ways to put a portfolio together. That's just one way, but we do have in the toolkit, there's a one pager under the getting started section about portfolios and the difference between a formative and a summative. And there's an example of a summative portfolio template for like advancement to the next PGY year. We haven't put a lot of examples. Some people use the built-in systems and new innovations and MedHub,
Yes.
and that certainly can be a place where you can load all of the documents. The reason we didn't stick with the one on MedHub was because we couldn't manipulate it very well. We couldn't customize it into folders. We really wanted to center it around the core outcomes so that it's useful. And it's hard, at least in MedHub, I don't know New Innovations as well, but it was harder to do that. I think New Innovations is a little bit more user-friendly, but OneNote is something we have subscription to through, the institution, and most of our residents said they used it as medical students to take notes or do other assignments and things. So they were actually more familiar with it than I was. I hadn't used it before. So it's very user friendly. It's easy to decide who has access and who doesn't, and you can get it at home anywhere you have internet. You can pull it up. So it kind of checked all the boxes for us.
Well, great. I think we're at time. Mario, yes?
We have a comments from Dr. Hassan. Says, thank you so much for the valuable info. Highly appreciated. We are a newly accredited internal medicine program in Las Cruces.
Congratulations. And for both of you starting new programs, yeah, it's exciting and terrifying, I'm sure, all at the same time. Like it would be wonderful, like Linda said, to be able to just build it from scratch like you want it, but that's also a lot of hard work. So
yes,
we appreciate you all.
Yes, and the STFM toolkit, Dr. San, is available to, you don't have to be a family physician. It's you don't have to have membership or anything. If you just click on it, you're in, and it has many, many resources that would be applicable to pretty much any specialty.
Yep. And if you lose the link, all you have to do is Google CBME toolkit, and it'll be the STFM toolkit will be the first thing that comes up.
Yes. Yeah.
All right. Well, thank you, everybody, for your time. I hope you have a good rest of your day.
Thank you. Bye-bye.
Yeah.